Hi there, and welcome to Plantar Plate Imaging. My name is Dr. Marlena Jabara, and I'm a board certified MSK podiatric radiologist. Let's take a look at part one, normal plantar plate anatomy. Our objectives together will be to review the clinical context of plantar plate imaging. We're going to discuss anatomic considerations in forefoot biomechanics, with a gross review of anatomy of the plantar plate. I'll provide you with an overview of normal MRI anatomy of our plantar plate and a normal MRI video case example, and we'll follow that with a review of plantar plate literature. So this is the type of medial toe crossover that we're looking to avoid in early plantar plate imaging and accurate diagnosis. By assessing the plantar plate at a stage earlier than the one seen here, we can prevent these gross malalignments that we can see in forefoot imaging. So what's happened here is that there's been a plantar plate tear at the second MTP joint, usually on the lateral or fibular side of the plantar plate. And you can see that that has rotated, and now we have a crossover of the second to the first toe. This can cause a host of issues, including pressure and ulcers from the crossover of the second to the first toe, and that's a serious consideration in our diabetic patient population. Let's take a look at how we begin, which is usually with our x-rays. So when we're looking at our x-rays, we really want to take a look at the lateral, where we can see a flexion deformity as seen here at the PIP joint, and that's called a hammer toe deformity. In addition, we can see the beginning on the frontal view of a medial toe crossover, where the skin of the second toe is beginning to come close to the first. And of course, looking at sesamoid rotation can give us a look at where we begin to have our greatest momentum of toe off. So as we shift the sesamoids over towards the fibular side, we can see that we're losing our sweet spot of the hallux MTP joint at our greatest point of toe off, and it's beginning to slide towards using the second MTP as additional toe off strength. X-rays can also tell us a lot about biomechanics when we look at our 3-view series. So after we've looked for our standard fractures and whether or not we have malalignments, including looking at the base of the second relative to the middle cuneiform to assess our Lisfranc injuries, we can begin to see other changes in bones that may tell us about biomechanical stressors, including what's seen here, which is this cortical thickening seen at the second metatarsal. In addition, notice it's slightly bowed. And so there have been changes perhaps in the biomechanics related to how we heel strike, move to the mid-tarsal region, move between early and late flat foot phase of gait, eventually to toe off, and the additional changes in the metatarsal alignment at the bases that can be seen when we need increased ground reactive forces to help us propel the patient from supination into pronation to toe off. And we can see what can happen is a hammer toe deformity as we begin to have second plantar plate tears. We can begin to wear out the plantar plate, creating a situation where we begin to have a hyperextension at that articulation and a resultant hammer toe deformity compensatory at the PIP joint. Furthermore, we can see that the forefoot in this case is beginning to spread out, where we have this overlap at the metatarsal bases, a situation that can be seen in metatarsus adductus or forefoot inversion. So I-inversion is where we're going to get the stacking of the metatarsals. So the additional second metatarsal stress can be seen here in this case by the cortical thickening. In other patients, we might actually see flattening of the second metatarsal head as the biomechanics of the second MTP joint is altered, creating a situation that creates accelerated osteoarthritis through our second MTP. Looking at anatomic considerations in metatarsal head size, we begin to see form and function. The first metatarsal head is responsible for a great amount of pressure experienced at the toe-off phase of gait, and it is wider rather than taller. In addition, there are sesamoids that fit into a helical articulation to help offload the great amount of forces that are experienced through the great toe during toe off. Looking at the lesser metatarsals, these are responsible for a great amount of load transfer. So they're taller rather than wider. Furthermore, looking at the first MTP joint, we have a sesamoid apparatus that is invested by the accessory collateral ligament. And that's different from the lesser metatarsals, which is the bulk of our conversation today. We're going to be taking a look, in this case, at the first MTP, which is sesamoid, the accessory collateral ligament. We have the proper collateral ligament, and that's going to adjoin some of the abductor hallucis, the muscle and the tendon, to reinforce the collateral ligament complex seen here. Furthermore, the space between the sesamoid and the base of the proximal phalanx is filled by the plantar plate at the center aspect of this articulation and on either side by the sesamoidal phalangeal ligaments. Removing the first metatarsal head, we can expose the plantar plate seen here with a star, and on either side, that's where we're seeing that sesamoid phalangeal ligament on either side of the plantar plate. Of course, the sesamoids are joined by the intersesamoidal ligament, and we can see the flexor hallucis tendon tunneling through the plantar aspect of this articulation with a fibroosseous tunnel that is extending itself towards the flexor hallucis brevis. So these are static and dynamic. The static considerations are the sesamoids and the dynamic stabilizers of the first MTP joint. Furthermore, at the first MTP joint, we have these collateral ligaments, and those are further reinforced medially with the abductor hallucis and laterally with the adductor hallucis, both the transverse head and the oblique head. Looking at the lesser MTP for anatomic considerations, we can take a view of the metatarsal and the proximal phalanx and begin to dissect away some of that anatomy. So I've drawn here the deep transverse metatarsal ligament, which forms the floor at the level of the metatarsal bases. The deep transverse metatarsal ligament meets the accessory collateral ligament at a point where they'll create a juncture at the plantar plate. So we can see that here in cross section. We have our plantar plate, and where it meets that deep transverse metatarsal ligament, that's when we have the investment of the accessory collateral ligament. Superficial to the accessory collateral ligament, we have the proper collateral ligament, and we also have the interosseous tendon coming through between these regions. So we've had the muscle moving into the tendon, and this interosseous tendon will join the lumbrical tendon past the point of the plantar plate at the MTP joint to form a further reinforcement of this oblique portion of the medial aspect or the tibial side of the plantar plate. So once again, the anatomy that we're looking at here is the plantar plate deep to the metatarsal head. We have the accessory collateral ligament, which is joined by the deep transverse metatarsal ligament at the level of the MTP joints. Furthermore, on the medial plantar aspect, we have reinforcements by the common tendons of the interosseous tendon and the lumbrical tendon reinforced on this medial tibial side. Of course, on the lateral side, we have the interosseous tendon forming further support at the juncture where the accessory collateral ligament is going to form with the deep transverse metatarsal ligament. And there's a lot of reinforcement on the curves because as the plate begins to wear out, we begin to have rotational malalignments, and there's reinforcement for that type of rotation. You can appreciate on this illustration how I've drawn in the plantar plate. It forms a hammock underneath the metatarsal phalangeal joint. So we can see that here, this whole black basket weaved underneath to support the MTP joint. Looking at the metatarsal heads in transverse, we can begin to appreciate we have those plantar plate, we have the accessory collateral ligament, and where that joins the deep transverse metatarsal ligament, we have that reinforcement. Of course, the proper and accessory collateral ligament really can't be dissected from one another in the course of reading an MRI if they're normal, because both are low signal and do not contain water. In between the articulations of, say, M2, metatarsal 2, and metatarsal 3, we have the metatarsal bursa, and that's a potential space that can become inflamed and enlarged during times where we have rotational or increased stressors at the metatarsal head. Of course, I've left out, let's just go through the entire bit of anatomy, going through the entire circular apparatus of the axial image. With our extensor digitorum longus and brevis tendon, we have our sagittal bands that keep the tendon centrally located. This blends imperceptibly to the region of where we have our proper and then our accessory collateral ligament. Of course, that again is going to blend into the region where it joins the deep transverse metatarsal ligament at the level of the metatarsal head, and then to the plantar plate we go. Of course, we have our flexor digitorum and flexor digitorum brevis tendons joined by its flexor tendon sheath. We have neurovascular bundles that are superficial to the deep transverse metatarsal ligament as seen here and here. Furthermore, I've added in our interosseous tendon and the lumbrical tendon here seen as separate decussated areas at the level of the metatarsal, and they'll join to form a common tendon band that will reinforce the medial aspect of the capsule. And of course, on the lateral aspect, we'll have that interosseous tendon that can reinforce that capsule on the fibular side. Looking at plantar plate imaging in the cadaver, which the surgeon wants to master, of course, we can dissect from the dorsal aspect of the articulation The proximal phalanx is seen in the lower part of the image, the metatarsal head seen in the upper part of the image. Once we dissect through those extensor tendons, the digitorum brevis and the longus, we get to expose the bony structure seen shiny here, exposing the capsular contents and removing the metatarsal head. We can expose the plantar plate. And the plantar plate seen here in the gross specimen to the right, we can see that shiny plantar plate, that plantar oval shaped structure that's about 2 centimeters long and about 2 millimeters in thickness. 2 to 5 millimeters is what it's been described as. And we can see on either side of the plantar plate the capsular areas of thickening. Here, the plantar plate has been drawn up for us to show us that cross-sectional thickness of about 2 to 5 millimeters. And of course, we can see for a second, I wanted to just stop and give us some inkling of what's to come in terms of the plantar plate pathology. So when tears occur at the plantar plate, it's going to be seen in early stage tears to have a transverse rent or transverse tear. So we'll be tearing medial to lateral in this case. But as the tear becomes a higher grade, 3s and 4s, we're having a longitudinal extent of tear. And that's a tear that's going to dissect along the longitudinal fibers and allow what's called buttonholing to occur, where the metatarsal head can actually penetrate through the plantar plate itself and, of course, dislocate. Plantar plate MRI protocol, just a second. I'd like to talk about using the proper field of view. In order to see the forefoot, you'd want to use a field of view that's no more than about 8 to 10 centimeters in total field of view. And of course, the slice thickness, being that we're looking at structures that are on the order of between 2 to 5 millimeters, we'd like a section thickness of about 3 millimeters and no more than that on any of the given sequences. Of course, high resolution imaging, always better for these small structures to be able to define them with clarity and accuracy. Now let's turn to the MRI. So what I've loaded up here are sagittal and transaxial images, and that's really the workhorse of defining plantar plate imaging. So we can see in this sagittal image, what I've loaded up is that you can see the plantar plate itself as this low signal band imperceptibly drawn to the flexor tendon itself. We can see some of the intermediate signal intensity at the level of the cartilage, the hyaline cartilage that divides the metatarsal head and the proximal phalangeal base. Of course, this is cortical bone, which is of lower signal intensity than the marrow element seen here, which is of slightly higher intensity, slight amount of physiologic joint fluid seen here. Looking at the transaxial image, we can see where we're looking for is a U-shaped structure as we described in our illustrations, looking from the region of the flexor tendon to the level of the plantar plate, of course, in the region of the accessory and proper collateral ligament, which we really can't dissect off of one another in the normal situation. So this is at the level of the typical rectangular shaped metatarsal head that is taller rather than wider. And here we can even see some of the attachment of the phalanx, so the plantar plate phalangeal ligament at its typical triangular shaped proximal phalangeal base. And of course, just to throw in for extra, there we can see our sesamoid complex, we can see the flexor tendon, and of course the collateral ligaments and the accessory collateral ligaments reinforced with our the beginnings of our first plantar plate complex beginning at the metatarsal side. So here's anatomic considerations at that distal attachment loaded up for us so we can see a better example of what it looks like at the attachment of the distal plantar plate phalangeal attachment seen here with low signal paired attachments on the proximal phalangeal base. I'd like to make a note about a normal plantar plate recess, which is generally thought to be no greater than 2.5 millimeters in width. So at the central aspect of the joint space, we have a normal recess that we can see from medial to lateral will seal up and become a formed attachment between the plantar plate and the proximal phalangeal base. But at the center aspect of the articulation, there is this normal recess that's usually on the order of 2.5 millimeters. And I'd like to show you now an example of a normal MRI of plantar plate imaging. Let's take a look at this example of a female 48 years old who presents with forefoot pain. In this case, I have an example of a normal plantar plate to show us. When we're looking at forefoot issues in general, we'll be looking heavily at the transaxial and the sagittal images. The sagittal images give us a great idea regarding the biomechanical alignment of the foot. at least in this position. And the axial images really help us to dissect out the individual anatomy, slice by slice and millimeter by millimeter. What I've loaded up for us here are 3 fluid-sensitive sequences, all with fat suppression. I also have one T1 weighted sequence, which is where the fat in the intramedullary canal and the subcutaneous regions are demonstrated. Looking further at these images, taking a closer look at the sagittal images, let's take a look at the second metatarsal phalangeal joint, looking at the cortical bone of the metatarsal head and the proximal phalangeal base and the fat suppression. We'll be looking to see whether or not there's any kind of stress response or fracture in these bones. Looking further, we can identify right away that plantar plate 2 centimeters long, roughly 2 millimeters in thickness, no elevated signal within the plate, at least seen here. We do see this region here consistent with a plantar plate recess. That would be no greater than 2.5 millimeter, and we can measure that here in any plane. So here, again, pretty constant at 2.5 millimeter or less. We can see the plate firmly attaching to the proximal phalangeal base as seen here. We can also appreciate the flexor tendon as it approaches the joint line, and then we'll continue on the digitorum longus, moving to the distal phalanx. Moving to the transaxial image, we can appreciate moving from proximal to distal, the U-shaped structure of the plantar plate, how it blends into the region of what will form the flaw and the deep transverse intermetatarsal ligament region. Here's your flexor tendon with its flexor tunnel, and we move into the plantar plate, moving into the region of the metatarsal head. And once we're at the point of the deep transverse intermetatarsal ligament, we can begin to consider these the accessory collateral ligaments and the proper collateral ligament. Furthermore, at the level of the deep transverse intermetatarsal ligament region, we're going to begin to form a convergence of the interosseous tendons with the proximal phalangeal base at that level. We're going to join the lumbrical tendon and form a thickening of that interosseous tendon complex here. This one is slightly thickened, and this one is more on the normal order here. But nonetheless, what that represents is a superficial reinforcement of the whole plantar complex. And many times we can see that that is either thickened or torn. So in the case of a normal plantar plate, again, what we'll be looking for is that U-shaped plantar structure, the plantar plate, blending imperceptibly with the flexor tendon. We'll be able to see the accessory and the proper collateral ligaments as a complete U-shaped structure supporting the MTP joint. We will begin to see reinforcements at the tibial side of the distal joint capsule, where the interosseous tendons of the dorsal and plantar interosseous musculature will join up and form reinforcements all along that medial side of the capsule. And that is your normal plantar plate imaging. A few more things we'll look at besides just the plate. We'll be looking at the region of the intermetatarsal bursa. We can see that again transaxially as the interosseous tendons decussate and move towards their capsular. They create a potential space that can fill as a bursa, and that's your intermetatarsal bursa. The deep transverse intermetatarsal ligament being the structure between M2 and M3. That's the terms given to metatarsals. And then superficial to that region, you can see the nerve artery vein complex. And then distal to that region, we'll begin to see further changes of the interdigital nerve. And we can see that with detail on T1. So here what you're seeing are at the level of the proximal phalangeal base, distal now you're seeing the two limbs of the nerve that have the interdigital nerve that have come together in this region here. And again, moving back into the foot, we're looking at the muscles of the dorsal and plantar interosseous musculature that are basically forming the capsular reinforcements that further support the medial plantar complex seen here. And the presence of a neuroma generally is thought to occur from friction against the deep transverse intermetatarsal ligament. So when we have a neuroma, it is felt to be a symmetric enlargement in the middle of this interspace. But a pseudoneuroma lesion, which I'll show you other examples in other videos, you'll start to see that the enlargement of the nerve moves towards one of the regions of the plantar capsule. And that's indicative that the region for the neuromatous inflammation is secondary to a plantar capsulitis. So distinguishing the type of inflammatory or perineural fibrosis that's occurring may help us to further distinguish our patients and help them find their forefoot wellness again. Thank you for your time and attention. Now let's take a look at a review of literature important to plantar plate imaging today. Whenever I'm thinking about interpreting MRI imaging, I always like to start with some idea of the biomechanics involved, and ground reactive forces is the name of the game for metatarsal and plantar plate tears. How much time we spend on the ground, how much pressure, what inclination, what degree of pressure does that metatarsal head feel will tell us something about the ability of its structures to withstand those moments, forces, and vectors. So in this case, the diagram is well laid out by Kirby that the plantar fascia contracts against the plantar plate. And if this reverse windlass mechanism is working, it should pull the toe down to the ground, and that will enable you to toe off and propel yourself forward. When I'm thinking about how to apply any of what I see, or I'm seeing a case, it always helps if I go to a site that I love. RadSource has been a great boost for education, and I think that these clinics and these small chapters that show a general case really have helped me a long way in understanding. So in this case, they give you an example of a 56-year-old female with gradual onset of forefoot pain. And you can see that this MRI through the forefoot is showing some pathology in the region of the plantar plate. As we've come to see, we can see that there's some subluxation or incongruency of the second. And we'll take a look at the findings as they explain them to us. And we can see that direct, complete discontinuity of the plantar plate here. We can see this discontinuity of the proper portion of the collateral ligament and that medial toe deviation, widening, or what's called splaying between the second and third, and they give it that diagnosis. So RadSource is wonderful, and I really think that the illustration here hits home that anatomy we talked about. If we looked at the third metatarsal head and we understood that deep to the head, there's that thickened plantar plate, relatively speaking, about 2 millimeters in thickness, about 2 centimeters in length, about 8 to 10 millimeters in width, connecting to the accessory collateral ligaments, which are invested superiorly dorsally by the proper collateral ligaments. That deep transverse intermetatarsal band separating out that region of the flexor tendon from the neurovascular bundle. So these articles and illustrations help us to understand some of the complex anatomy that we are up against when we're trying to understand how the metatarsal ground reactive forces are affecting this entire complex. Generally speaking, after reviewing this, we've seen that we're going to be looking for that U-shaped structure, looking at the flexor tendon, again, looking at the accessory and the proper collateral ligament and the collateral ligaments. I really like RadSource because it also goes to explain not only complete tears, but partial tears, which can be subtle and showing as this focal fluid intensity on stir imaging in that case. This, a complete tear of the lateral proper collateral ligament with that medial deviation, and that splay finding we'll take a look has been written up. If you see a dislocation, definitely means that you've had a plantar plate tear, and it can even be a very thin plantar plate, so you may not even see it. Again, gives you some guidance to the clinical diagnosis and management, and helps us to understand how the clinician is actually stressing this. And these features here can help us understand how we might better serve our clients and patients in ultrasound, where we're doing a lot of this dynamic imaging. In looking at some of the great original work that's done in this area, I really learned a lot from this predictive MRI correlates of lesser MTP joint tears by Ullmans and Elzinger. And this, they looked at control cases of different reasons why the forefoot would have some kind of pain. They separated all the different reasons out. They looked at patients who had plantar plate tears, and they looked at some of the features that are associated with plantar plate tears. And they did some interesting things. And I think this is biomechanically what leads us to some of the problems. And they were looking at the rotational axis of deviation. Now, if you've been in any of my classes, you hear me talk about flattening of the forefoot parabola. And there are different ways we can flatten. The metatarsal head, these lesser metatarsals, can rotate towards the great toe. And when it does that, what it's doing is a forefoot varus. So basically, it's supinating the forefoot and moving the forefoot into that varus position. Oppositely, we can see that the great toe is coming in this medial direction in a pronating stance. And so they looked very interestingly at the convergence. So they found that when the great toe, the pronation moment and the supination moment, when it was greater than 45 degrees of an axis of rotation, that was an issue that predisposed the patient to plantar plate tears. And they also looked at just this rotation, but I think they found it to be too tedious to actually measure it. But I think it's an observation that we can make, and it might be helpful for the clinician to understand that in the neutral position, when the patient's laying in neutral position in our magnet, that this is the general rotation of the axis. This might also help to explain why more commonly the tears are on the fibular side of the plantar plate complex, often affecting the interosseous membrane, the lumbrical, that whole complex, and the lateral aspect of the plate. Of course, they also talked about splaying of the toes, the second and third being a predictor, a secondary sign that you might have a real issue regarding the plantar plate. And also, again, looking at that eccentric pericapsular fibrosis. And that was one of the most important additions to the literature, the differentiation between what it meant to have a pseudoneuroma and what it meant to have an interspaced neuroma. And it's important to differentiate. They point out that it's particularly problematic as treatment varies dramatically and misdiagnosis and mistreatment can cause prolonged pain. And forefoot dysfunction is something that we encounter clinically over and over again. So I think adding to it would be to add in the MRI some of the features of what we're seeing. And I simply state this out as metatarsus adductus, or rotation of the plantar bases towards the great toe, just to give an idea. And I do talk about the forefoot parabola. Furthermore, they looked at many different indicators as to sensitivity, specificity, and accuracy of these indirect MRI features in detecting plantar plate tears. So they looked at things like dorsal subluxation, pseudoneuromas, proximal phalangeal bone marrow edema. And this is a great article out of AJR from 2017, second and third MTP plantar plate tears, Yamada and their group. Amazing work that really, I think, put plantar plate imaging on the map as something that you will find most radiologists reporting whether or not the plantar capsules are intact, and picking apart that you need excellent quality in order to see these structures. So having slice thickness of 3 and 4 millimeters, as we've talked about in the lecture, and having a smaller field of view, the field of view being on the order of 8 to 10 centimeters, and not trying to take in the entire foot, are parts of your clinical excellence and putting into your imaging so that you can get images that with clarity show the plantar plate as a structure invested into the proximal phalangeal base, looking at the flexor tendon here, the U-shaped structure, helping us to pick out where the flexor tendon and tunnel is with regards to the plantar plate, the accessory collateral ligament and the proper collateral ligament, that thinner band. Furthermore, giving us excellent demonstrations of what it meant to have this pericapsular eccentric soft tissue swelling that we can see here. If we dropped and bisected that midline, we can see that a portion of this eccentric pericapsular fibrosis is hugging this metatarsal head, and that's indicative of the pseudoneuroma sign. And we can contrast that to a neuroma where there's a central thickening of the interdigital nerve. It's still considered pericapsular fibrosis, but it's more global, and it's felt to be compression against the deep transverse intermetatarsal ligament. Furthermore, they propose a grading system that really helps us to understand that tears less than 50%, partial tears, and that's very common. You'll see a lot of that. And the kinds of tears that you for sure want to pick up would be 3s and 4s, where you're certainly seeing involvement not only of the tear, but also secondary structures, now collateral ligaments, beginning to show signs of instability, right? And of course, buttonholing tears, where the metatarsal head is moving through the plantar complex. Furthermore, direct features, they outline clearly for us partial or complete discontinuity, seen in 13 out of 34 patients. Thinning, these are other signs. So thinning of the distal insertion, non-visualization of the plantar plate was something that was occasionally seen. Any change in the morphology, so morphologic changes were present in all of them. So having that sensitive eye to detect may help us to start to see these tears at all. Of course, I leave this for you to evaluate because I think everything in this article is important, including the imaging, which helps us to find this interosseous tendon thickening. This is an earlier sign that I see very common in patients who have early plantar plate dysfunction. Notice the pericapsular inflammation. In this different patient, they're showing us that plantar plate proximal phalangeal distance line. And they again talk about the association between those indirect features with plantar plated surgery. So almost all of these patients that had a pseudoneuroma sign had a plantar plate at surgery. And interosseous tendon collateral ligament complex, many of them also had that. So being able to identify these features with clarity will help us to stratify our patients. And when we look at where this becomes important, I really think that this particular chapter that puts it together for us at MR imaging of the plantar plate, that normal anatomy, turf toe, and other injuries, they go through the entire constellation of forefoot imaging. And I suggest for anyone in the business to really be picking apart this. They go through all of the anatomic features that I've started to describe, the different shapes of the metatarsal heads, the great toe being larger and the second metatarsal head being taller rather than wider, and what these features mean. And just to skip down to things like that are occurring at the lesser plates, we're looking at that crossover deformity, giving us excellent pictures clinically to help us with our MRI read to understand what we're trying to do when we're moving that classification system to help our clinicians. Again, those examples of a full dorsal dislocation. In this article, again, reviewing for us some of the features that might predispose us to plate tears at all. Having second metatarsal head protrusion may indicate that there's a greater driver of the metatarsal ground reactive forces. So things like this may predispose the patient or may be indicating that we indeed are having more pressure on a plantar plate. These are normal examples. They move to abnormal examples, this being a normal sonogram and this being the abnormal, the hypoechoic region of the tear in this area of discontinuity of the plantar plate seen on ultrasound. So they give us an idea of what we can see. But what is really the power of this article is it also brings a lot of the clinical portions home by talking about the treatment and what we can do for our patients. So where in the past they did not have great surgical techniques, now they have restoration techniques of joint function, soft tissue transfers and reconstruction that can really help stabilize these lesser MTP joints and are showing to have greater success. But what we can do is help them to understand what is the degree of dysfunction that the patient is showing on the MRI by looking at the metatarsal parabola, letting them know about the ability of a head protrusion or their goals, helping them to reduce pressure under the metatarsal head. What do we see on the MRI to help alleviate that? Does the patient have a pes cavus or different things like that? And so I think that these great articles that I presented between the original articles, Brad Source, and understanding the biomechanics really help us to hit home and impact the treatment outcomes for our patients with forefoot pain. Thank you. References available for your review. And lastly, our summary. What we've done together is we've reviewed the clinical context of plantar plate imaging. We've discussed forefoot biomechanics and had a gross review of plantar plate anatomy. We've provided an overview of normal anatomy of the plantar plate and provided a case example in video format. Lastly, we finished with review of supporting literature, and I hope you've enjoyed this first presentation on plantar plate anatomy and will join us for part 2 coming next in MRI plantar plate pathology. Thank you again. Welcome back to plantar plate imaging. We're up to part 2, plantar plate pathology. Let's take a look. Again, our objectives today will be to review the clinical context of plantar plate imaging. I'll discuss clinical features of plantar plate pathology and take a case-based review of plantar plate tears, including capsulitis. Again, this is what we're trying to prevent, the classic crossover toe seen with usual second MTP or metatarsal phalangeal plantar plate tears. What happens here is that the plantar plate tears and creates a metatarsal malalignment which rotates the second MTP over to the first. So what we've seen usually is that there's tears of the lateral plantar plate at the second MTP joint, which crosses over to the second toe. And ulcers can cross and be created deep to the crossover toe, which can be a devastating complication in the diabetic foot. Taking a look at forefoot biomechanics through reading of our x-rays, after we've gone through our usual interrogation of reading a normal x-ray, which in the forefoot will include not only looking for fractures, any kind of transverse infraction, of course, looking for AVN, looking for Freiberg's infraction, understanding the alignment that the second metatarsal base needs to articulate with the middle cuneiform, that we don't have any Lisfranc malalignment. We begin to further look at subtle clues of the biomechanics. And in this case, again, we can see here that the thickening of the cortex may indicate an increased biomechanical load or even a prior healed stress fracture. We can begin to understand the alignment of the first MTP joint and the position of the sesamoids. Are they rotating towards the first interspace? Something that can be seen with uncompensated biomechanics, including rear foot varus. Take a look at the overlap at the metatarsal bases. Is it overlapping to a greater degree? Do we have the second, third, fourth all overlap? Or are they underlapped in a case of forefoot eversion? So we're looking for forefoot overlap, which is a common finding when we see overload at the medial aspects of the first and second MTP joints. So in addition, we can see in this case, there's even a subtle sclerosis seen in the proximal phalangeal bases. And how we can tell that is that in the normal state, the epiphysis is generally becoming fatty. And here we can see even the relative sclerosis to lucency, we can see there's an increased degree of sclerosis in this portion of the articulation. In addition, on lateral projections, we can pay close attention to the detection of hammer toes. And this is a great place to stop and see. Hammer toes are generally a result of hyperextension at the MTP and a flexion, a compensatory flexion at the PIP. Of course, we can have toe clawing, where we can have flexion deformity at the PIP and DIP in a state that can be seen also in neuropathic articulations. And of course, mallet toe is a different entity where we have flexion deformity reserved just for the DIP joint, and usually the PIP joint is in extension. So these are close things that we can pay attention to when we're looking to see whether or not we have malalignments that may indicate that we have increased forefoot biomechanical overload. Of course, we can always look for second toe crossover, which we don't have here, but what we do have here is a subtle malalignment deformity between the second DIP and the third DIP, almost on the order of a bowing or splay deformity seen here. In further reviewing anatomic considerations of the lesser metatarsal phalangeal joints, we can take a look at a metatarsal and the proximal phalangeal base, reviewing that that's supported at its plantar aspect by the plantar plate, identified here as the small triangular shaped basket structure. That's going to join your accessory collateral ligament to the deep transverse metatarsal ligament and form further reinforcement at the medial side. We can see that that's further reinforced at the level of the metatarsal phalangeal joint with the interosseous and the lumbrical tendon. And of course, superficial to the plantar plate, we have our paired flexor digitorum brevis and flexor digitorum longus with a tendon sheath. We have the neurovascular bundle, which is superficial to that DTML. Of course, we have the intermetatarsal bursae on either side to help cushion different rotational pressures that the metatarsal heads experience during metatarsal head purchase. Looking at the anatomic considerations of the metatarsals as they're lined up from M2 to metatarsal 4, we can appreciate the plantar plate as it joins that accessory collateral ligament and the proper collateral ligament superficial to that. And of course, our DTML, our deep transverse metatarsal ligament. We can appreciate the location of our neurovascular bundle. This will be the source of where we either find a pseudoneuroma, something that is a pericapsular fibrotic change to the nerve that's hugging the actual plantar plate, or whether it's centered midline, which would be a typical Morton's neuroma that's felt to be created by the pressure against the DTML. And I'll talk about that again in further tutorials. Looking at plantar plate imaging, we can appreciate the gross anatomic specimen seen here on the left with its 2 centimeter long plantar plate and about 2 to 5 millimeters in thickness and about 5 to 8 millimeters in width. Dissecting through the dorsal apparatus, we can divide the extensor tendons, exposing the metatarsal phalangeal joint, resecting the metatarsal head. We can expose that plantar plate seen here in the gross specimen, picking up the plantar plate where we can appreciate that 2 to 5 millimeter in thickness that we can see here. Again, about 5 to 8 millimeter in width and 2 centimeter in length. Looking at plantar plate imaging with MRI, we really can appreciate that pericapsular thickening. We can see tears, ganglia, pseudoneuromas, cartilage loss, bone changes, and of course associated metatarsal head, rotational malalignments, metatarsus adductus deformities, and even forefoot varus and valgus. We can see here on these examples, the plantar plate has been retracted and pulled away, and we can see a gap that's greater than 2.5 millimeters. Here we can see that transverse greater than 50% of the thickness of the plantar plate and the pericapsular soft tissue change that has infiltrated this T1 weighted image. Looking at the clinical grading of plantar plate tears, it helps to understand the tear of what you're trying to diagnose prior to looking at the image, understanding grade 0 being normal, grade 1 being less than 50% of the tear of the thickness along that plate that we've been looking at. And of course, grade 2 can go completely across, but it still does not actually lose all of the fiber strength that's still reinforced at the medial and lateral aspects of the capsule. So grade 2 can be complete transverse tears. Grade 3 is a combination of 7 or a T or an inverted 7 shape. And grade 4 can be an extensive tear with buttonholing so that the metatarsal head can probe through a defect and have a dislocation. Looking at plantar plate direct and indirect tears, we can see it just like I explained in that first example. The plantar plate here has been torn and retracted and there's a gap, and that's a direct sign, as opposed to an indirect sign seen here where we can see that there is bone marrow edema along the proximal phalangeal base, but we can also see the plantar plate. But indirect signs that we're having a plantar plate tear is the increased stress that the proximal phalangeal base is experiencing, and also the presence of this pericapsular inflammation called capsulitis. And when we're looking at transverse images, we can appreciate the soft tissue swelling deep to the plantar plate region. In addition, we can see the actual irregularity in the region of the interosseous tendon and plantar plate tear as it attaches along that deep transverse intermetatarsal ligament. So we're seeing a plantar plate tear here. And of course, we're seeing bone marrow edema at the proximal phalangeal base in this patient that has a direct evidence of a plantar plate tear and actual stress response at the proximal phalangeal base. Looking at anatomic considerations of plantar plate tear, we see a direct tear. We see a gap of greater than 2.5 millimeters, not in the midline, and we can see that the plantar plate itself has retracted. Furthermore, tear has been described as thinning. Chronic tears can be thinned and attenuated. Again, we're looking for those types of tears going from transverse low-grade tears of grade 1 where they're transverse less than 50% or grade 2 fully across, to grade 3 where there's a longitudinal extent of the tear. And of course, those inverted T or 7-shaped grade 3 tears are of course buttonholing tears at grade 4. Here we can see that this is a transverse tear that's extending greater than 50% of the way from the level of the region of the recess through that medial side. So this would be on the order of a grade 2 type of tear. Secondary signs include plantar capsulitis seen here. Looking at the interosseous tendon thickening seen here, that collateral ligament tendon thickening is demonstrating plantar capsulitis, that this patient is experiencing a pathology consistent with a partial tear of the plantar plate with plantar capsulitis and interosseous tendon thickening. Let's take a look at a video of a partial tear with capsulitis. Great. So let's take a look at this 59-year-old gentleman who presents with forefoot pain, metatarsalgia. And when we're evaluating the plantar plate, it's useful to load up the axial and sagittal sequences to see these small structures. And when we're evaluating this, we can first have an understanding of the forefoot parabola and notice that there is an inverted forefoot parabola here. It's relatively flattened. When we look at the dropping of the metatarsal heads and we begin to examine the soft tissues, we can see the soft tissue swelling consistent with plantar capsulitis. In evaluating the plantar plate, we're going to be looking for a typical U-shaped structure. Remember the flexor tendon, the plantar plate itself, the accessory to the proper collateral ligament. In this case, when we look at the second MTP, we can appreciate the flexor tendon and the plantar plate itself. This is a measurement of what would have been the recess, but it's larger than 2.5. It's closer to almost 4 millimeters, 3.87. And this is a widened recess. Let's take a look at that transaxially and understand that recess extends to this tibial side of the distal plantar plate. And that's consistent with a partial tear. Notice that rent right at the tibial side of the distal plantar plate attachment and the associated plantar capsulitis, the soft tissue swelling that's occurring superficial to the second MTP joint. And lastly, we'll talk later on downstream about the fact that this non-neuromatous lesion is holding closer to the second MTP joint capsule in a patient who has a pseudoneuroma. So putting it all together, we have a partial tear of the second MTP plantar plate at that distal phalangeal attachment. We have associated plantar capsulitis and a small pseudoneuroma. Thank you. Taking a look at anatomic considerations in pseudoneuromas, pseudoneuromas have been discovered to be associated with plantar plate tears, and this is where you have pericapsular fibrosis. that is associated eccentrically with the plantar capsule. So in this case seen here, we can see this enlargement of the nerve and the pericapsular fibrosis or inflammatory change that's lying closer to the joint capsule and seen here contiguous with the plantar plate tear itself. And how we'll assess these will be to drop a bisecting line through the region of the proximal phalanx or the metatarsal region. And we want to see whether or not the perineural fibrosis seen here lies closer to one capsule or another. And if it's eccentric and lying closer to the plantar capsule, we can term this pseudoneuroma. And pseudoneuromas have been an important secondary sign in detecting plantar plate pathology. References available for your review. In summary, we've reviewed the clinical and radiologic anatomy of lesser plantar plates. I've taken you through primary and secondary MRI features of plantar plate anatomy and pathology with case example, and we've started to review neuromas versus pseudoneuromas. Stay tuned for our next tutorial where I'll take you through an in-depth look of neuromas and pseudoneuromas. Thanks again. We're up to part 3, neuromas versus pseudoneuromas. Let's take a look together. Our objectives will be to provide an overview of normal anatomy of the lesser plantar plate. Again, I'll review MR features of neuroma. We'll review Mulder's ultrasound maneuver to detect neuromas, and I'll discuss pseudoneuromas versus neuromas. Again, anatomic considerations in the classic crossover toe deformity are what we're trying to prevent. By using MRI for early diagnosis and accurate strategy, we can prevent these types of malalignments that occur secondary to plantar plate pathology. In this case, the second plantar plate has torn, creating a rotational malalignment where the second toe is now rotated over the great toe. This can cause a good amount of pressure deep to the skin surface and create ulcerations, which can be devastating in our diabetic foot population. In addition, forefoot biomechanics is at risk here, and we can see that we can have further complications upstream with our ankle, knee, hips, and spine. Again, looking at anatomic considerations, again, a review of our metatarsal region and the proximal phalanx, looking at the plantar plate, which is going to be the supporting fibrocartilaginous structure deep to the metatarsal phalangeal joint. That's going to be reinforced by the accessory collateral ligament and the proper collateral ligament. Furthermore, on medial or lateral aspects of the plantar plate, we are joined by the DTML or the deep transverse metatarsal ligament. We can see all of this very well with transaxial imaging. Seen here in this illustration, we have our plantar plate, and that's joined by our accessory collateral ligament. We have the proper. On the medial border, we have additional reinforcements through the lumbrical. We also have our interosseous tendon, which will join the lumbrical distally, provide further capsular reinforcement. In addition, we have an interosseous tendon on the lateral aspects, and that further reinforces the lateral aspect of the capsule. Again, noting that neurovascular bundle at the plantar aspect or superficial to our DTML. We have our extensor tendons joined by our sagittal bands to the level of the collateral ligaments, and of course our flexor tendons joined to the plantar plate through the flexor tendon sheath. Joining our metatarsals together, we can understand metatarsal head purchase and forefoot biomechanics by looking at how metatarsal 2 to metatarsal 4 are related through our plantar plate complex, through the deep transverse metatarsal ligament. Our plantar plate complex, of course, is further reinforced by the accessory collateral ligament and the proper collateral ligament. On the medial borders, we additionally have our interosseous lumbrical along the lesser MTPs. And on the fibular side or the lateral side, we have reinforcements through our interosseous tendons. We can appreciate the paired extensor digitorum brevis and longus and the flexor digitorum brevis and longus and their flexor tendon sheaths. Looking at indirect signs of plantar plate, it's important to understand the concept of pseudoneuromas because it has been noted that pseudoneuroma sign, or the presence of having eccentric perineural fibrosis, was seen in the majority of patients that went to surgery for plantar plate tears. So you were more likely to have a surgically diagnosable plantar plate tear in the presence of having a pseudoneuroma. So we're going to be looking on MRI to be able to detect that sign so that we can furthermore see some of the harder to see plantar plate tears. But what we're essentially looking at is a region of eccentric perineural fibrosis seen here by these arrows that are detecting that the interneural changes have occurred closer to the plantar plate, and therefore the greater amount of pressure experienced on that portion of the nerve may be secondary to a malalignment based on plantar plate pathomechanics. So Morton's neuromas are neuromas that occur in the midline and felt to be compressed against the deep transverse intermetatarsal ligament at the level of the metatarsal heads. And we can differentiate that from a pseudoneuroma, which is felt to be eccentric perineal fibrosis closer to a plantar plate capsule. It's important to differentiate between neuromas, which are central, and eccentric pseudoneuromas because the treatment for plantar plate is very different from the treatment of Morton's neuroma, and we can improve patient outcomes with early, accurate diagnosis. So once again, if the enlargement of the perineal fibrosis is midline, that will be termed Morton's neuroma. If it's eccentric, it's more likely to be related to plantar capsulitis and plantar plate tears, and we'll call that pseudoneuroma. The diagnosis of Morton's neuroma is made identifying an oval mass with variable echogenicity, ranging from homogeneously anechoic to heterogeneously hypoechoic, associated with increased vascularity. We'll look to perform a sonographic Mulder sign, looking most commonly in the third metatarsal space between the third and fourth metatarsal heads, but also at the second intermetatarsal space, with the second most common. Of course, the differential diagnosis we're looking for is to differentiate a Morton's neuroma from intermetatarsal bursitis or even a plantar plate injury. Performing a sonographic Mulder's maneuver helps to make the Morton's neuroma become more conspicuous on ultrasound using medial to lateral compression. So we'll be looking at the level of the interspace to see whether or not we can have the neuroma move from the region of the intermetatarsal bursa where it lives, press upon the level of the deep transverse intermetatarsal ligament. Let's take a look in this dynamic Mulder's maneuver ultrasound. Sonography of the forefoot is frequently requested to investigate causes of interdigital foot pain. This can be performed using dorsal or plantar approaches. We use the Mulder's clinical test, which is a well-known maneuver in which compression of the metatarsal heads produces a palpable click. That's secondary to the displacement of the intermetatarsal mass, in most cases a neuroma. When we use sonography, we can apply pressure to the plantar aspect of the intermetatarsal soft tissues to improve visualization. When we grasp the metatarsal head regions from medial to lateral and we apply pressure, we can create a more conspicuous appearance of the interdigital nerve and help to increase that diagnostic sensitivity of the exam. Let's take a look. So in this case, what we're looking at is the region of the third interspace. Between the second and third intermetatarsal heads, we see the cortical bone and the shadowing beneath it. In the interspace, we see the hypoechoic Y-shaped interdigital nerve, and we can appreciate that pressure from the external and internal aspects of the metatarsal head regions can create a situation making the interdigital nerve more conspicuous as it protrudes into the subcutaneous fat. And of course, we can measure that. So this is the Mulder's maneuver. Again, the hypoechoic perineural fibrosis surrounding the nerve, protruding through the interspace when compressed from medial to lateral, the Mulder's maneuver. Now let's highlight pseudoneuromas. Pseudoneuromas is the situation where you have eccentric pericapsular fibrosis within that intermetatarsal space. So let's take a look. We have the enlargement of the region of the intermetatarsal space, and within that we have the enlargement of the interdigital nerve, and we can see the elevated signal intensity denoting the pericapsular soft tissue swelling. And on T1 weighted image, we can see that that has replaced the fat and created a fibrofatty inflammatory change that's lying closer to the second MTP joint capsule in a situation that's best termed out as a pseudoneuroma. By terming it out as a pseudoneuroma, we're more likely to alert the clinician that what we need to treat here is a plantar plate tear. Now let's take a look at a video of a pseudoneuroma. This case, we're assessing this large M3, M4 interdigital lesion, all the features of this enlarged interdigital nerve. And we're now assessing again the difference between a neuroma and the non-neuromatous lesions. Those non-neuromatous lesions would be seen in association with the plantar plate tear, and like some Morton's neuromas, it may have intermediate signal intensity on T1 and T2 weighted images. So what we can see here is enlargement of this interdigital nerve. We can also see there is a large defect in the plantar plate attachment through the interosseous musculature. We have tears of the accessory and the proper collateral ligament on this side. When we look at these sagittal images, we can see an actual defect in the plantar plate gapping itself. We see very thin, stretched out, torn appearance of the lateral side of the plantar plate here, as evidenced here. And what we have is this enlargement of the interdigital nerve and edema, stress-related change and erosion, actually, at the third metatarsal head and at the fifth as well. This is a patient that likely has underlying inflammatory arthritis, as seen here with these erosions almost at all the MTP. In this distribution, we'd favor rheumatoid arthritis as the etiology. So we have this large interdigital enlargement. It is composed of this fibrosis, this perineural fibrosis, that is seen in both Morton's neuromas and pseudoneuromas. So let's take a look at an unusual case where we have a very large interdigital nerve. We can see there's inflammation surrounding this region, as seen here in the intermetatarsal bursa. When we look at its relationship to the plantar plate, we can see that there is an associated plantar plate tear at the lateral aspect of the third. Also note that there are erosions and bone marrow edema not only at M3 but also M5, M1. In a case like this, we would suggest that there's underlying rheumatoid arthritis. Getting back to this lesion, as has been described, this pericapsular fibrosis accompanies most cases of plantar plate tears. And in fact, it's a very important early sign to pick up, again, because these pericapsular pseudoneuromas can identify a plate tear at an earlier sign in the disease than was previously thought. So in the past, if we were to think that this enlargement of the interdigital nerve was a neuroma and we treated the neuroma, we would miss the fact that there is a large tear of the fibular side of this plantar plate. And you can see on the sagittal images just how thinned out and torn this plate is and the stress-related edema that's occurring in the metatarsal head. Also notice the exaggerated joint effusion and the cartilage loss in this location. So pseudoneuromas and neuromas do have a crossover, especially when they're this large. This one causing certainly probably a degree of pain and mass effect, exacerbating the erosion and altered biomechanics. I'm certain that the patient probably experiences a click. Now let's take a look at this fourth interspace where we can see this enlargement of the interdigital nerve here, and we can see the two limbs. And again, there is some kind of inflammatory change or this intermediate T1 and T2 signal lying closer to the fifth MTP joint, which also has a very large tear of its plantar plate itself. We can't even identify a normal U-shaped structure to even say where that plate is. And when we look at the sagittal images, you can appreciate the high-grade tear that's occurring on the fibular side of this articulation. So again, pseudoneuromas versus neuromas, the important distinction is twofold. Eccentric pericapsular fibrosis, now recognized as an important and useful correlate. It can be more readily apparent than a small defect in the plantar plate itself, so we're going to pay close attention to any pericapsular capsulitis or synovitis so that we can avoid misdiagnosing those as neuromas. Thank you. References available for your review. In summary, we've reviewed clinical and radiologic anatomy of the lesser plantar plates. We've reviewed neuromas and pseudoneuromas. I've discussed dynamic ultrasounds to assess metatarsalgia, including using the Mulder's maneuver. I've used a video case example of an MRI of a pseudoneuroma to help us assess this. Thank you again for your time and attention. It's been a pleasure. My name is Dr. Marlena Jabara, RadPod Squad. Let's take a look at part 4, dynamic ultrasound evaluation of the plantar plate. In this tutorial, we're going to discuss clinical grading of plantar plate tears. I'm going to review Mulder's ultrasound maneuver to detect neuromas. We'll review dynamic plantar plate imaging for instability, looking at Lachman's maneuver of a vertical stress test. And I'll take you through some video case examples of ultrasounds of plantar plate tears. Let's take a look together. Anatomic considerations in the classic crossover toe deformity. This is the situation where you have a plantar plate tear that has occurred usually on the lateral border, in this case at the second metatarsal phalangeal joint, and that has created a situation that has allowed a metatarsal rotational malalignment. That second toe is now flexed at the PIP joint and able to cross over to the great toe. This is going to create a good amount of pressure between the second toe and the first toe, and an ulcer can form. And that can have devastating complications for our diabetic patients. And furthermore, accurate diagnosis early on may help to avoid and prevent these types of malalignments that can put our patients at future risk. Let's take a look now at the Mulder's maneuver. The Mulder's maneuver is where we're going to compress the foot from medial to lateral and be able to create a situation where an interdigital lesion may become more conspicuous on ultrasound with medial to lateral compression. In this case, we can see that there is fullness of this interspace as a compression between the first and the fifth occurred to create a situation that had an audible click, where we were able to see the protrusion of the interdigital nerve pushing along the deep transverse intermetatarsal ligament. Let's take a look at this dynamic ultrasound of this Morton's maneuver. We can see in this region this interdigital nerve seen as a hypoechoic lesion pushing through the region of the deep transverse intermetatarsal ligament, and of course partially reducing in this situation that has likely a tear also of the plantar plate. So that is an example of how Mulder's maneuver can create a more conspicuous situation where we can see the interdigital nerve creating a protrusion through the level of the deep transverse intermetatarsal ligament, a situation that can be addressed using the Mulder's maneuver. Anatomic considerations when we're looking at MTP joint instability, it's good to understand Lachman's MTP drawer test, and that will be helpful to assess the degree of subluxation or dislocation under stress. So in grade 1, the joint is less than 50% dissociable. Grade 2, greater than 50%. Grade 3, completely can dislocate it. And grade 4, it's dislocated at rest. When we're taking a look at these things, we can really see with clarity under ultrasound the anatomy of the plantar plate. So in this example, we have the sagittal plane loaded up here. We have the second MTP joint, and this is the normal appearance of the plantar plate as a labral-like, slightly echogenic structure, which is generally homogeneous. And we can see that it's going to blend imperceptibly here, this region here, to the level of the flexor tendon. We can see this is the flexor tendon with the flexor tendon fibrils. So the plantar plate. And of course, deep to that, we have the hyaline cartilage of the metatarsal head. We have the proximal phalangeal base with its cortical bone and the intramedullary bone. And in this case, we can see an actual tear of the plantar plate. So where we had that labral-like, slightly echogenic structure, now we have this hypoechoic area of discontinuity seen in a plantar plate tear on ultrasound. Looking at the Lachman's maneuver for plantar plate tear, we can appreciate using that dynamic maneuver here, where we're going to take the proximal phalanx seen at the left of the image, and we're going to dorsiflex that, and we're going to understand the relationship of the region of the plantar plate seen with the hypoechoic tear seen here, the plantar plate itself seen here, the flexor tendon seen here. And we can see that region of hypoechoic. We can also measure the degree of subluxation of the proximal phalangeal base relative to the metatarsal head, and we can gain a measurement of that to have a reproducible example for our clinicians. So we can measure that between here, and of course, we will have an understanding of the metatarsal head size, and we can see in this case it was less than 50%. So less than 50% dissociable, and we see an actual partial tear of the plantar plate. So a partial tear, low grade, plantar plate less than 50% subluxable. And of course, here we can see that in a static image, that hypoechoic rent seen within the region of the plantar plate. In this example here, we can see even before we begin that the level of the proximal phalanx is on a level that is not sweet to the level of the metatarsal head. And of course, when the patient begins to have a toe off, they're going to actually reach the ground with the proximal phalangeal base first, which will certainly set up a lot of dysfunction. But let's take a look. And what we're seeing here at the proximal phalangeal base, as we plantar flex this, we're beginning to have a situation where we can dissociate the articulation. We're seeing a partial tear of the plantar plate itself as it attaches on the proximal phalanx, this rent here. Of course, we can see that it's going less than 50%, and we're going to then sublux or attempt to try to sublux this articulation. Noticing the tear here. It's less noticeable as we move from medial to lateral. So as we can see here, we can see the tear with a greater degree of conspicuity off to one side. And then as the operator moves from medial to lateral, we can appreciate that is not a full thickness transverse tear. So again, a partial tear, less than 50% subluxation of the plantar plate, and we can see that with clarity on this ultrasound. References available for your review. So in summary, we've discussed dynamic ultrasound to assess metatarsalgia, including the Mulder's and Lachman's maneuver, and we've taken a look at the review of current literature. Thank you for your time and attention. My name is Dr. Marlena Jabara, and this is a presentation of RadPod Squad. Thanks again. This is part 5. We'll be taking a look at plantar plate case pathology, taking a look at different cases. Our objectives together will be to review video case examples of plantar plate pathology. Let's take a look. Looking at anatomic considerations of a classic crossover toe deformity, this is the situation we're trying to prevent. We're looking at second metatarsal phalangeal tears, creating a situation where you have a rotational malalignment where the second toe can cross over to the first. Generally, this is on the lateral aspect of the plantar plate and can create a situation where we have ulcers and increased pressure. And that can be devastating when we consider the effect of our patient population who is afflicted with diabetes. So by accurately diagnosing plantar plate tears at an earlier stage, we may be able to impact forefoot biomechanics. Let's take a look. Here are some plantar plate case examples for your review. So let's take a look at this case. I'm a female with forefoot pain, 35 years old. When I'm first looking at the case, first I try to get a sense of the biomechanics. I try to understand the forefoot parabola and the convergence of the second metatarsal, usually with the hallux. In this case, I notice that the patient has a bunion, cystic change, mild surrounding stress-related edema. I can appreciate the degenerative change along the tibial sesamoid with the helical complex. And I try to understand whether or not there's a medial crossover occurring that would be more likely for me to understand or predict whether or not there'd be a plantar plate tear. And in this case, we can see that the distal phalanx turns medially, and we have this medial crossover, this mild medial crossover where the skin between the first and second are compressed. And we get a sense here of this phenomenon where the rotation of the hallux and the second metatarsal is putting it in closer proximity. Additionally, I'll take a look at the forefoot parabola in general because I'd like to understand if this patient has neuropathic change or what is the degree of pressure. And in this case, this parabola has this appearance of this type of forefoot supination mechanic. And I'd predict that this patient had some kind of pes cavus. So moving on from that point, looking at the plantar plate complex, understanding the increased pericapsular soft tissue thickening that I see here. Secondary signs such as a pseudoneuroma that we discussed are where we're going to assess this region of the interdigital nerve. This is the nerve. This is perineural fibrosis. And it has been found for you to guide you to assessing whether or not that this is a lesion associated with the plantar plate pathology, that you would construct and bisect a line. And if a portion of the neuroma or pseudoneuroma lies closer to the plantar plate issue, this is considered perineural fibrosis, and the etiology of this neuroma is based on that plantar plate instability. Looking at the anatomy that we talked about earlier, when we're thinking about the plantar plate complex, dissecting away the flexor tendon and the tenosynovitis that we see here. Moving towards the joint line, we understand the accessory collateral ligament to the proper collateral ligament here. And moving distally, in this case, we can see that there's a rent between where the plantar plate, which is the deeper 2 millimeter band, attaches to the accessory collateral ligament. Let's corroborate that on sagittal imaging so we can understand where we are at the metatarsal proximal attachment of the accessory collateral ligament. The plantar plate in this case being this band here. When we're moving over to the relatively more normal side, more the fibular side, looking at the plantar plate here, we can see that there's a gap in the region of the recess, which is rather sizable at 2.8. I usually allow for no greater than a 2 millimeter recess, usually on the order of 1 millimeter or less. When we look at another articulation to get an internal sense of reference, there's even some increased signal at this central region of plantar plate, but you can see that there's no actual fluid gap. When we compare that to the area of interest, we can see the much higher signal denoting synovitis and this 2.8 millimeter plantar plate to metatarsal head gap. Other secondary signs we can see here, proximal phalangeal edema. And when we look at this region here and corroborate that with the transaxial images, we can see that there's a rent, a partial tear here at the plantar plate distal attachment on the proximal phalanx, and we can see that here. In addition, we have a joint effusion, intermetatarsal bursitis, and mild flexor tendinosis. So altogether, I would term this out as a partial tear of the distal tibial-sided plantar plate and accessory collateral ligament involving approximately 50% with both transverse and longitudinal component. The longitudinal component can be difficult to see, but in this case, you can appreciate the length of this tear, that there is a tear extending in the sagittal plane. It's harder to see on the coronal images, but you can appreciate that in this region here. And that is a second MTP plantar plate tear, partial tear, high grade with proximal phalangeal stress-related edema and pseudoneuroma. Plantar plate tears are an increasingly recognized cause of metatarsalgia, and ultrasound evaluation is very useful in the longitudinal plane. We found that lesser MTP joint plantar plate tears are most common at the second MTP joint, and they tend to involve the lateral distal plate insertion. They can tear transverse and longitudinally, and it's variable depending on the biomechanics. The most common ultrasound appearance of a plantar plate tear will be a discrete hypoechoic defect in the plate substance. You can have thinning, flattening, and even non-visualization of the plantar plate, which may represent an extensive or chronic tear. We can see the typical secondary findings as well with pericapsular fibrosis and assess for the presence of pseudoneuromas and plantar plate distance. In this example here, looking at the second MTP plantar plate, what we can appreciate in the anatomy is the echogenic layer of the metatarsal head cortex. This is some of the hyaline cartilage. We have the plantar plate itself, which is about 2 millimeters in thickness and about 2 centimeters in length. We can see its attachment on the proximal phalangeal base, and we can see a partial tear at the superficial distal aspect with a hypoechoic region leading to the plantar soft tissue. So in this case, we can see that there's a partial tear of the superficial attachment of the plantar plate. It involves approximately 50% of the attachment if you drop a line here and then consider that there's about 50%. We can see some more hypoechoic regions closer to the midline, and then the tear resolves as we pass the midline here. As we perform the Lachman's test, we can see the excursion of the proximal phalanx relative to the metatarsal head, and we would have had a measurement of the metatarsal head denoting this is approximately 50% or greater in excursion with a partial tear and swelling extending to the superficial aspect of the plantar plate. And this would be reported as a high-grade partial tear of the plantar plate with greater than 50% head subluxation consistent with MTP joint instability. Looking at the region of the sesamoid complex, we can appreciate there's a sesamoidal rotation towards the first interspace. When we were born, we had helical sesamoidal facets, and we can see that this sesamoid is no longer articulating in its helical articulation, but rather moving towards the cristae, where there is some stress-related edema. So we can appreciate the hallux valgus deformity, the extensor tendon, some of the sprain of the sagittal band, the region of the bunion, the collateral ligament thickening, and the rotation of the sesamoid complex towards that first interspace. The altered biomechanics occurring at the second with an attempt towards a medial crossover, where we have a high-grade partial tear of the plantar plate at its attachment to the accessory collateral ligament. I term this out on the tibial side as opposed to the fibular side to help the surgeon identify where we are looking. We can see that plantar plate. We're going to look again again at the collateral ligament complex here and see the proper and again the tear of the accessory. Further things that we can see on this examination, intermetatarsal bursitis at the second interspace, and we can use our transaxial T2 or even T1 weighted images to get a sense of the neuroma that would live here, which you can see here, this Y-shaped structure that is measuring from here to here and from here to here. This is your neuroma. And again, we can even see that in the coronal plane where we can appreciate neuromas quite nicely on T1 weighted images, where we can appreciate the enlargement of the interdigital nerve seen here and the length of the interdigital nerve seen here. And we'd measure that. And if it's greater than 3 millimeters, that would be considered a functional neuroma. Now we talk about an extra wrinkle in plantar plate imaging called the pseudoneuroma, and that's when you have the situation where you can drop a bisection of the intermetatarsal bursa and the neuroma lies on one or another side closer to the plantar plate complex. As seen here, we have this extension of the neuroma towards the second plantar plate in a situation that would be termed a pseudoneuroma. So when the neuroma lies closer to one metatarsal or another, that's given the term pseudoneuroma and is felt to represent greater pericapsular fibrosis and inflammation secondary to instability of the plantar plate complex. References available for your review. So in summary, we reviewed some dynamic case examples of plantar plate pathology. I hope this presentation has been helpful for you. My name is Dr. Marlena Jabara. If it's been helpful, please check us out on school at RadPod Squad. Thanks again.